Friends, we have come to the last, but the most important session. Unfortunately, for last couple of years, this ethics session has been in the last, which is one of the most important. I think I'll request the organizers next year to keep it either before the lunch or immediately after the lunch. So many people can benefit the experience of Dr. Girish Tyagi, who has been speaking not only here, but the API Delhi chapter also in IMA. This is a very important session. Most of our complaint, people are living longer, living healthier, yet the apathy towards the profession is unabated. Every day you see there is a violence against the doctor, and yet, so we have to look within ourselves, we have to realize where we are going wrong, and here is a man who can tell you where we are going wrong and what we should do. Therefore, I request Dr. Girish Tyagi, who is the Secretary of the Delhi Medical Council for nearly a decade. He has a vast experience. He can tell us, give tips how to avoid these and be ethically correct. Thank you, Dr. Tyagi.
मेरे ख्याल सर इसमें because after this such hectic and academic topics, let us make it an interactive session so that first of all I will just talk about the DMC because we are receiving around 30 to 40 complaints per month. We are receiving around 30 to 40 complaints per month. That means 1 to 2 complaints per day we are receiving from different quarters, from directly from the patients, from the Delhi government, from the Medical Council of India, from police, from consumer court, from high court even, and of course pertaining to the professional misconduct and negligence against the doctors. When the complaint is received at Delhi Medical Council, it is put before the executive committee primarily for dismissing it or accepting it. If there is some substance, then of course it is being accepted, and we ask the concerned doctors or the hospital to reply to it. Then, based on the specialty with the expert, if still there are some issues involved, then it is sent to the disciplinary committee. In the disciplinary committee, we have a 6-member disciplinary committee, in which 3 are the medico and the 3 are the non-medico persons. 3 non-medico persons are, 1 MLA is there, 1 legal member is there, 1 eminent public man is there, and 3 medical persons are 1 representative for DMA, 1 chairman, of course, who is the medico, and 1 expert from the relevant specialty. So most of the time the issue which we are arriving at, because of communication and documentation, repeatedly we are telling that because of communication and documentation, we will end up in trouble. Either we doctors are neither good communicator and of course even lesser in the documentation part. If we are properly communicating with the patient, then of course number of complaints against the doctor will be reduced. If we are documenting it properly, then conviction against the doctors will be markedly reduced. So few things about that. I just narrate the A, B, C, D, E. A is the availability. Whenever the patient reaches a casualty or emergency, whether in the government sector or private sector, A is the availability in the form of manpower, machine or material. If the doctor or the nurse or the paramedic or nursing orderly is there, because at the government sector most of the time it is seen that the staff is less, doctors are less, nurse is not there, so availability of manpower. Then of course most of the time in the government sector it is seen that either the ECG machine is not working, CT machine is not working, or lab is not working, or X-ray machine is not working. Then whether sometime it is seen that the wheelchair is not there, stretcher is not there, and the patient relatives are asked to bring their patient to the various tests they have to trolley to the patient. So then B is the behavior of the doctor or whoever is involved with the treatment. Behavior is also very important. Then C is the communication. If we are properly communicating, then most of the things are over. D is the documentation. E is the empathy. And of course F is the financial part, which of course primarily with the private sector. So if we, because at the government is not, you can see the GDP of that, what the government is spending on the health, it is even lesser than the Bangladesh or the Nepal. So most of the time it is seen that the doctors are being ad hoc or contact, or all the staffs are, or sometimes it is seen that the department has been outsourced, they are not keeping it for that matter. So in the government sector, this is the cause of the violence or the assault, because the doctor is the person who patient thinks that they are paying directly to the doctor, or doctor is in charge, or doctor is responsible for providing all these facilities. So, and of course in the private sector, financial part is always there. Financial part means that once a patient is going with a certain budget, if complication occurs, then if the ICU stay or a patient on a ventilator, then the budget is changed, and once they are not getting the expected result, then of course mistrust, allegation, litigation, assault, these kind of things started. So communication, documentation, these are the things, and recently we are receiving the complaints against the doctor for issuing the medical certificates. For the false or the misleading medical certificates we are issuing to the patients, and we are receiving from the criminal court, from different organizations, from government, and from sometimes from the high court even. So we just issue the medical certificates to the request of the patient or the relatives, sometimes our friends, family or something like that, and they submit that medical certificate to organization where they send back to. Because sometimes it is in that the medical certificate, they just write a bottom that this certificate is not valid for medical legal purposes. They thought that once they have written that, it will serve the purpose. Any document signed by a physician, whether on a prescription paper, whether on a plain paper, whether without stamp, whether with the stamp, so once it reaches to any statutory authority, it becomes a legal document.
Even if it is not signed, because your
Handwriting.
so that is enough to
Yeah, so it becomes a legal document. And at Delhi Medical Council, we are doctor friendly, of course. If you are treating the patient in an ethical way, you have told to the patient, to the relatives, proper informed consent is there, and whatever the result may be. If some complication occur, patient has been operated, some complication occur, you have told before starting the treatment about the patient, about the complication and the thing, you have apprehended that complication, you have tried to treat that complication, whatever the result may be, including the death. If you are, it is documented. First, documentation, of course, very, very important. If the documentation is there, and then nobody can take action against you. That means you will not be convicted. Of course, it is the right of the patient to file a complaint. You will get a notice from different authorities to respond to that. It is a harassment, of course. You will be harassed for that. Once a notice from that, any authority, any statutory came to any person, there is a mental tension for that matter. And maybe चाहे income tax हो, चाहे court का summon हो, चाहे medical council का letter हो, of course you get tension. But if you are properly documenting it and working in an ethical way, you will not be convicted. Harassment can be there, but conviction will not be there. So these are the few things which I just want to narrate. And of course, it is open for discussion, then of course we can discuss.
Thank you, Dr. Tyagi. Just want to add a couple of, want to share some information. The MCI curriculum has been revised from this year itself, 2019, and in all the 350 medical colleges throughout the country, the new curriculum has come in. And it is because of medical ethics, importantly, medical ethics, that the curriculum has been revised, and the MCI has added 140 new hours of medical teaching which are dedicated only and only to medical ethics. And it starts from first year itself. It is not going to wait till forensic medicine is going to come up, and it is divided in 4 years. Now we will have 4 professionals, first, second, third, and it is called PY 1, 2, 3, 4, professional year 1, 2, 3, 4. And from the medical ethics teaching starts from first day of the MBBS. And for the first month, it is called as a foundation course, and there is no formal teaching, mind you, anatomy, physiology, biochemistry, community medicine, there is no formal teaching for the first month of MBBS. It has already started in all the colleges, MAMC and every college in the country from this session. And in the first month, their teachings are only medical ethics. And it is not a, directed lecture, one teacher teaching the students. It is an interactive session. There are skits, there are problem solving rounds. Students are involved into their given problems and they are supposed to give their opinion, and then with legal and ethical input, they are told the solutions of these problems. And this is based upon lot of hard work by the MCI, meetings, deliberations, presentations lasting for more than 5 years throughout the experts involving, from medical colleges of almost more than 100 colleges throughout the country. And then they prepared this curriculum called as AETCOM module, AETCOM. It is Attitude, Ethics and Communications, which is the core of these 140 hours of medical ethics teaching in MBBS curriculum. So this involves about 30 hours each in all the 4 professional years, total to be completed about 140 hours. And forensic medicine itself will cover almost 2 years now instead of 1.5 years earlier. I'll give an example, very practical example. Patient comes to you, he says that I am going to get married, so I want to get my HIV test done. You get this test done, he is HIV positive. By chance or whatever, he says that, my would-to-be wife has some questions with you. So she wants to know, कि डॉक्टर साहब मैंने भी अपना टेस्ट कराना है क्या? आप कहते हैं करा लीजिए. So what was the status of HIV test of my would-to-be husband? Now, can you share this with this girl or not? So these are the very practical questions which come to you. You do not, maybe we might falter, we might be scared, we might have to call up a lawyer, but this is part and parcel of MBBS itself. What do you do in such a situation? Can you divulge the would-to-be husband's HIV positive status with the bride? Yes or no? Sorry? Sorry, sir? Yes. Yes. There has been a very famous case regarding this very situation, almost about 13-14 years back, and the Supreme Court very rightly says yes. Because, and for example, his brother comes to you and says, or maybe parents, I want to know the HIV status of my son. Can you share that to him?
You can say no.
So because, these are subtle but very, very important things, because who is going to be affected by his HIV positive status? The partner, sexual partner only. So wife hai, she is the only one who is going to get affected. So any girl, अच्छा कल उससे रिश्ता टूट गया, फिर सुप्रीम कोर्ट में गया था, and the doctor one who divulged the case, divulged the HIV status, so he has a right to give that information to his would-to-be wife. So any other girl who is going to be married to this guy has a right to know the HIV status of her would-to-be husband. So these are very practical issues that are there, and we are the generation who are facing the maximum brunt of violence against doctors, So we have to probably look at, and the National Medical Council is going to come up in about 2 months now. So they are going to have this, ethics in details as part of their rules and regulations. So this was something that I wanted to share with you. Anything else you want?
For example, he is having diabetes, he is having coronary artery disease, and he comes to you for simple cold or cough or fever. Are we supposed to write down all the medicines which he is taking, maybe from some other hospital, or we simply write about those few 2-3 medicines for the cold? And
it is your wish, but yes, it makes sense to give that proper history that he is already on treatment, papers screened. If you are writing, that is an important thing that you have gone through that, and patient is advised to continue the same treatment. However, this is my advice. So that suffices that you have been given a legal background. The idea is legal, the legal background of whatever papers you've screened. And when you say that it's screened, advised to continue same, that is enough.
Because, sir, when the patient is being seen, because history taking, before starting the treatment is the duty of the history taking. History taking, of course, when you are history taking, you have to mention that, because prescription, two documents, one is prescription, another is discharge summary, which are with the patients only. So if there is any deficiency on the prescription OPD card or in the discharge summary, then of course, regarding that indoor patients in the files, whatever they are written, it will come to say after a few months or few years, but prescription and discharge summary, you have to be very careful before handing over to the patient. It should be properly. In one of the case, patient going to a Delhi government hospital, smaller hospital, patient was critical, it was seen by a RMO at that hospital, and it was referred to that bigger hospital. In between the patient, in the transportation, the patient expires. When that patient reaches that tertiary hospital of the government, Delhi government hospital, patient expired, MLC was made. So ultimately the case came to Delhi Medical Council, and in that the prescription which was submitted by that duty doctor at the small hospital, in which the name etc. written, then the patient critical referred to higher center. No other parameter was mentioned, no pulse, no blood pressure, no SpO2, no anything for the matter. How can you judge the criticality of the patient without these parameters? You are writing only case patient critical referred to it. So prescription is very, very important, and of course history, what are the investigation, what you have to mention on the prescription. Of course it is difficult at the government sector as well as the private sector, but seeing the present scenario, the hostility of that, of course all the maybe media, patients, police also, we should be very careful.
Common scenario of CGHS patient requesting for 3 months prescription, 4 months prescription.
DMC is very clear about it. It is given in many judgments. Dr. Girish Tyagi के signature से ही गया है. There are specific guidelines not to make the medical certificate more than 15 days at a time.
Not medical certificate. CGHS patients come in OPD review. They want doctor साहब 3 महीने का ही लिख दो.
डॉक्टर साहब, जो आप 3 महीने लिख रहे हो, 6 महीने लिख रहे हो, 15 दिन लिख रहे हो, इट इज द डॉक्टर्स रेस्पॉन्सिबिलिटी. अगर आपको लग रहा है, डोंट गो बाय दैट कि सीजीएचएस के आरएमएल के प्रोफेसर ने, एचओडी ने क्या लिखा है. इफ यू आर कन्विंस्ड that patient requires such and such treatment for such and such day, because ultimately based on your prescription he will get in the medicine.
It should be justifiable.
It should be justified.
It is all right.
What do we write? Patient says, डॉक्टर साहब आप तो लिख देते हो 15 दिन बाद आना है, वो दवा 15 दिन की देते हैं, 15 दिन तो वेटिंग में लग जाते हैं. वो बोलता 3 महीने की लिख दो. Can we write the prolonged treatment, chronic illness treatment for 3 months with proper care or monitoring of BP and sugar? Can you justify the treatment
for 3 months?
With proper care and monitoring of BP and sugar?
If you can justify...
And to review more frequently while the long-term medications remain the same. Can we write something of that?
Yes,
डॉक्टर साहब, पहले तो आपको कन्विंस होना पड़ेगा कि जो आप लिख रहे हैं, if you are convinced कि इसको 3 महीने की जरूरत है, you should be convinced first of all, not कि patient क्या चाह रहा है.
I'm asking the question back to you. Can you write for 3 months?
Yeah, we can write.
Then it is
anti-diabetic. We can write for 3 months with proper care and monitoring.
That is the answer.
While we ask them to review more frequently for follow-up.
डॉक्टर साहब, साथ में जो आप लिख रहे हो 3 महीने के लिए, उसमें किस कंडीशन में पेशेंट को वापस आकर को बताना है. In case of such and such, please report to your nearest hospital, nearest doctor. It should be mentioned. Not that कि आपने 3 मंथ के लिख दिया, उसको पेशेंट को पता ही नहीं कि इसकी पेशेंट जो ड्रग दे रहा है उसकी क्या कॉम्प्लिकेशन हो सकती है. इट शुड बी टोल्ड. मुश्किल है, बट आपको जो एक बार कहीं से पुलिस का एक बार नोटिस आएगा डॉक्टर साहब, तो एक बार नींद तो गायब हो ही जाएगी ना. तो उस नींद को बचाने के लिए बेटर है कि आप अपने सेफ्टी के लिए और अपना रिलैक्सेशन के लिए यू शुड बी वेरी केयरफुल.
राइट.
डॉक्टर साहब, गवर्नमेंट हॉस्पिटल की भी हमारे पास, इंक्लूडिंग एम्स की भी हमारे पास कंप्लेंट आ रही है. वी आर एग्जामिनिंग द एम्स, सफदरजंग, लेडी हार्डिंग, सबकी आ रही हैं. जो अब तक कंप्लेंट, क्योंकि आप गवर्नमेंट अस्पताल में इसलिए कंप्लेंट नहीं कर रहा कि पेशेंट आपका लाल बहादुर शास्त्री में गरीब तबके का इंसान जा रहा है, जो कि सर रोटी तक ही सीमित हो गया. थोड़ा सा भी कोई पेशेंट जाएगा, अगर उसको आपने 3 महीने की दवाई लिख दी उसको, और उसको पता नहीं कि उसको उसकी हाइपरटेंशन की आपने लिखी कि उसका ब्लड प्रेशर कम होगा, तो यार डायबिटीज की दवाई है तो उसका हाइपोग्लाइसीमिया में जा रहा है, तो उसको कब कैसे पता पड़ेगा? इट शुड बी डॉक्यूमेंटेड, इट शुड बी टोल्ड टू द पेशेंट, क्योंकि एक पेशेंट कोई भी कंप्लेंट करेगा. वी आर गेटिंग द कंप्लेंट फ्रॉम द ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज, व्हिच इज अ प्रीमियर इंस्टीट्यूट.
So one just practical question for, I think everybody, it concerns all the private doctors. Serious patient, they bring to the hospital nursing home, they deposit an instrument of 5,000 rupees, patient serious, 2 days, 3 days, 4 days, nobody deposits in single money, we keep on doing every day. There are lots of investigations required, treatment is required, everything required, CT, MRI, blood investigation. What is our responsibility in that? When they are not submitting any advance for the treatment of the patient.
सर ये तो जो फाइनेंशियल वाला इशू है ना, तो दैट इज ऑफ कोर्स वेरी ट्रिकी इशू. जब आप पेशेंट को एडमिट कर रहे हैं, उसको बता रहे हैं, उसको जो उसका नहीं सबमिट कर रहा हो, इफ द पेशेंट इज स्टेबल यू कैन डिस्चार्ज हिम. इफ द पेशेंट इज स्टेबल, इफ द पेशेंट इज नॉट स्टेबल, क्योंकि आप उसको ट्रीटमेंट रोक नहीं सकते उसको सर लीगली. और उसको अगर देयर आर अदर वेज टू गेट द मनी. गेट द मनी मीन्स कि आप उसको जो लीगल नोटिस देके कोर्ट से पैसे लेते रहे, बट ऑफ कोर्स इट इज डिफिकल्ट.
पर ट्रीटमेंट देना है.
ट्रीटमेंट तो सर आपको, अगर पेशेंट को जरूरत है, अगर पेशेंट रिक्वायर्स, इमरजेंसी नहीं है, पहली चीज तो सर इमरजेंसी उसको हैंडल करो. उसको पेशेंट स्टेबल हो गया, यू कैन रेफर द पेशेंट टू एनी प्लेस, बट इमरजेंसी पीरियड उसका वे ऑफ करके, मतलब इमरजेंसी उसकी हैंडल हो गई, पेशेंट स्टेबल हो गया, देन ऑफ कोर्स यू कैन रेफर द पेशेंट. और जो 5-7 हज़ार 8 हज़ार का नुकसान है, वो बेशक से मान के चलो कि आप महीने में कुछ फंड ऐसा रख लो जो कि एक आपका जो सरप्लस फंड है, जो कि आपको इसी काम के लिए इस्तेमाल करना पड़ेगा, ये मान के चलो सर.
नहीं सर, वेंटिलेटर पेशेंट चला जाता है, लाखों का होता है, वेंटिलेटर पे चला गया तो उनके काम हो गए, एंड वी कांट अफोर्ड नॉट टू put him off the ventilator.
Dr. Lochan, we cannot afford the time now. You can discuss the problems with Dr. Tyagi. Dr. Tyagi, kindly excuse us. We have to vacate this hall and we are limited for time. We are already overshooted the time. Thank you very much. We declare this session closed.
Thank you, sir. And
जुगत लगानी होगी.
I would request Dr. Arjun Singh, sir, kindly felicitate our speaker and chairpersons. And it's my, before concluding this conference, it's my duty to sincerely thanks everyone including delegates, speakers, chairpersons, executive members, namely Dr. Vijay Arora sir, Dr. S.K. Gupta sir, Dr. Ashok, Dr. Lalit, Dr. Paras, Dr. Lauti, Dr. Rajiv Gupta, Dr. Grover, Dr. Pankaj Chaudhary, Dr. Naresh, Dr. Lauti, Dr. Kapil Khanna, and everyone. Pharma industry, without their support, this conference would not have been with success. Hotel staff, and last but not the least, the Mr. Shambhu. Thank you everyone to make this conference a great success. Thank you. See you in MidCon.